Hi, I'm Melanie Morin.
I'm Shay Brotherston.
I'm Emily Miller.
And today we're going to talk about childhood obesity in Canada. So, what's the definition of childhood obesity? So first we'll look at body mass index, or BMI. This is measured and used to determine childhood overweight and obesity. Overweight is defined as a BMI at or above the 85th percentile and below the 95th percentile for children and teens of the same age and sex. Obesity is defined as a BMI at or above the 95th percentile for children and teens of the same age and sex. BMI is calculated by dividing a person's weight in kilograms by the square of height in meters. For children and teens, BMI is age and sex specific and is also often referred to as BMI for age. A child's weight status is determined using an age and sex-specific percentile for BMI rather than the BMI categories used for adults. This is because children's body's composition varies as they age and varies between boys and girls. Therefore, BMI levels among children and teens need to be expressed relative to other children of the same age and sex. Increases in childhood obesity have been reported using BMI, waist circumference, and skin fold measurements. Results from the Canadian Institute for Health Information suggest that increases in BMI among children and youth are associated with greater adiposity instead of greater muscularity. Now for the epidemiology. According to measured height and weight data from 2007 to 2009, children and youth aged 6 to 17 were 8.6% were obese, and earlier estimates suggest that 6.3% of children aged 2 to 5 are obese. Obesity among young children in Aboriginal populations is high, but tends to be lower among youth across all Aboriginal groups. At the provincial and territorial level, differences are statistically significant in Alberta, Manitoba, Ontario, and Quebec. First Nations off reserve, according to the Aboriginal People's Survey in 2006, 20% of children ages 6 to 14 were estimated to be obese. This information was not available for children under 6 or 15 and older. The Métis, according to 2006 APS, children between 6 and 14, there was 16.9% that were obese. The Inuit, according to the same survey, they surveyed 25.6% of children being obese as well. So next we have the determinants and contributions. Obesity is a very complex condition and has many causes. A high level of screen time is associated with a greater likelihood of being obese for Canadian adults and children. Screen time is influenced by a number of demographic and socioeconomic factors, which includes age, sex, education, household income, and urban versus rural residency. The Canadian physical activity levels among youth study estimated that during the 2007 to 2009 period, 88% of children and youth aged 5 to 19 did not meet the guidelines of Canada's Physical Activity Guide. According to the 2009 report card on physical activity for children and youth by Active Healthy Kids Canada, only 19% of children and youth are currently meeting the guideline of less than 2 hours per day of screen time. Familial and environmental factors may be associated with dietary choices and behaviors. So, consuming sugar-sweetened beverages between meals, skipping breakfast, have been associated with an increased risk of obesity in children and youth. Food insecurity or income-related problem in assessing food during the preschool years has been found to increase the likelihood of overweight later in childhood. Analysis have been shown that indicators of neighborhood level SES are correlated with obesity in children and youth. School-based intervention of children and youth, so therefore increased frequency/duration of physical education classes, and also additional training for teachers, for example. Studies from other jurisdictions have suggested that environmental factors such as lack of safe and accessible spaces for children to play, and also a built environment that promotes motorized transportation over active commuting, just like cycling and walking, can serve as barriers to physical activity. So why should we be concerned about childhood obesity? There is significant evidence that obesity is at least partly genetic, but this also affects more than just appearance. So there are consequences on health and well-being: high blood pressure, raised cholesterol and insulin levels, impaired glucose tolerance, type 2 diabetes, bone and joint problems, obstructive sleep apnea, asthma attacks, non-alcoholic fatty liver disease, kidney problems, polycystic ovary syndrome, poor self-esteem, and depression. Although not every obese child will have these health problems, doctors are seeing many of these problems in younger and younger children. So for an example, the incidence of type 2 diabetes has increased rapidly in teens, with obesity present in virtually all cases. So in addition to obese children are more likely to be obese as adults. Thus, obesity puts a child's health at lifelong higher risk. Next, we have research. So there was a systematic review of the clinical literature found associations between obesity and the incidence of type 2 diabetes, asthma, gallbladder disease, osteoarthritis, chronic back pain, several types of cancers like colorectal, kidney, breast, endometrial, ovarian, and pancreatic cancers, and also major types of cardiovascular diseases like hypertension, strokes, congestive heart failure, and coronary artery disease. There may also be a relation between psychiatric conditions and excess weight. However, this may be confounded by the fact that some psychotropic medications can contribute to weight gain. Evidence from other systemic reviews indicate that childhood obesity increases the risk of obesity during later life and contributes to the early development of a number of conditions, such as type 2 diabetes and heart disease and high blood pressure. In most age groups of children and youth, according to self-reported and measured data, obesity is more prevalent among boys than girls. There are a number of research gaps and methodological challenges in studying obesity in this population, including different systems for defining overweight and obesity at different ages and the study of prevalence among very young children. The development of improved measurement, ongoing surveillance, and longitudinal studies could help to enhance the understanding of obesity in children and youth. Without intervention, overweight infants and young children will likely continue to be overweight during childhood, adolescence, and adulthood. Obesity in childhood is associated with a wide range of serious health complications and an increased risk of premature onset of illnesses. This includes diabetes and heart disease. So more research and information are definitely needed about the effectiveness, transferability, and generalizability and value for money of prevention and management interventions, particularly in preschool-aged children. Next, we have the history of obesity in Canada. So Canada, like many nations, is in the midst of an epidemic of overweight and obesity. There has been a dramatic increase in unhealthy weights in Canada. Childhood overweight and obesity has been rising steadily in Canada in recent decades, or the past 25 years. Between 1978 and 1979 and 2004, the combined prevalence of overweight and obesity among those aged 2 to 17 years increased from 15% to 26%. This is a 70% increase. Increases were highest among youth aged 12 to 17 years, with overweight and obesity more than doubling for this age group, from 14% to 29%. In 2013, 42 million infants and young children were affected by obesity.
Stats Canada found that in 2014, 6.2% of Canadian children aged 2 to 17 had a BMI that ranked them as obese. This equals approximately 125,000 children. 16.9% of children were ranked overweight by their BMI, equaling about 343,000 children. Together, nearly 25% of Canadian children are considered overweight or obese. This is clearly a huge epidemic in Canada, and we need to do something about it. In this graph, we can see how the numbers of both overweight and obese children have increased significantly over the past 10 years. The light blue represents the total of children, the dark blue represents the overweight youths, and the red represents the obese youths. In this graph, it demonstrates the numbers of both boys and girls that are overweight or obese in Canada. The blue line being boys and the red line being girls. As we can see, childhood obesity affects boys significantly more than it does girls. A study found that infants who were fed only formula were more likely to be obese when compared to those who were fed either formula and breast milk or only breast milk. Also, infants who were fed a combination of breast milk and formula were more likely to become overweight than those who were fed only breast milk. Breast milk can also have a preventative effect on obesity. We should try to promote breastfeeding for a longer duration to decrease the prevalence of childhood obesity in Canada. Another study found that as the availability of healthy snacks increased, so did the purchase of them. If healthy snacks are more available to children, they will get purchased. This means that in order to make a population healthier, we should have more healthy snacks available to the children. This here is a video of a news report of one of the contestants on The Biggest Loser in the season featuring kids. Noah was an 8th grader who enjoyed playing sports but struggled to keep up with his friends due to his weight and breathlessness. Throughout the program, he learned lots about nutrition and how to deal with stress in ways other than eating. Throughout the program, he lost 55 pounds and feels much better and is able to keep up with his friends. This source was not balanced because it only mentions how Noah felt about his condition and what he was doing to gain weight. It also fails to mention anything about the long-term complications that come with childhood obesity, which often leads to adult obesity, and any other physical effects that obesity has on the body. To name a few, this includes hypertension, risk of heart complications, and joint problems.
There are many different people who are involved in the healthcare of many different patients. All these people work together for one common goal, the health of the patient. The team includes the family doctor, the nurses, and the patients themselves. Childhood obesity is on the rise in Canada, and it is important for the family doctor to be well connected to the patients and their families. If the doctor is well connected to their patients, they are more likely to produce healthier behaviors in place of abnormal, unhealthy behaviors. The doctor will work with the patient and their families to find most suitable exercise programs and diet plan for that individual. The nurses. Children are in contact with nurses in many different settings, including school, doctors' offices, clinics, and hospitals. For nurses who are combating childhood obesity, they are particularly focusing on children ages 6 to 12 years. Statistics Canada says that 32% of children aged 5 to 17 are overweight or obese. In interventions based through schools, there was a great decrease in childhood obesity rate in students aged 6 to 12 years. RNs, whose practice includes prevention of obesity and promoting a healthy lifestyle, should utilize many different interventions that target that problematic age range, like diet as well as exercise. These interventions will help prevent ongoing obesity struggles later in life. Lastly is the patient. It's the patient's responsibility to find motivation to adhere to the program they are in. They must have the support of their family and friends to keep them motivated. The patient must understand how beneficial a healthy lifestyle is and how important it is to maintain that lifestyle. Education is key for them. Whether the patient is in the exercise and diet program for a change in body weight and health, or to maintain their already healthy body weight and lifestyle, the patient must have self-motivation and an understanding of what they are participating in. A healthy change starts with the patient. There are many different decision makers when it comes to childhood obesity. Canada's federal and provincial governments are working together to promote a healthy weight and lifestyle for people of all ages, especially children, so they can have a healthier start in life. This video from the Public Health Agency of Canada promoting a healthy lifestyle and showing other efforts to decrease childhood obesity. So this is curbing childhood obesity. A healthy change starts with the patient. The Canadian government put together a framework for action to promote healthy weights. This framework is in efforts to control the growing issue of childhood obesity. More than 1 in 4 children in Canada are overweight or obese. Children are also suffering from diseases like diabetes and high blood pressure, which would normally be seen in adults. This framework is designed to give children the healthiest start they can possibly receive. It is made up of 3 different but integrated strategies. First, making childhood overweight and obesity is a collective priority for action. This means it is being made an issue for all members of authority, and action is being taken to decrease these rates. Coordinating efforts is the next strategy. In order to make a change, a child needs a supportive environment. Early detection, parents should encourage activity and less screen time, and nutritious foods, which means less McDonald's and more fruits and veggies. Lastly, measuring and reporting on collective progress is important to track changes in the childhood obesity rate and be able to adjust the intervention strategically. Thank you for listening to our presentation today. We hope you enjoyed it.